I'm going to be presenting this case study, and it will be talking about a patient specifically who has HIV and also some other factors that you need to make sure that you take into account when treating patients with HIV. So we're going to start with an introduction, just going over HIV, what it is, and then how that affects amputees and everything, and then we're going to get into our specific patient, his case features, how we chose to treat him, and then my references. All right, so HIV is the human immunodeficiency virus, and it's a retrovirus, and basically what it does is it attacks CD4 T cells, which are immune cells. So when it attacks those cells, you're basically left with fewer immune cells, meaning you are now immunocompromised. You are not as capable at defending yourself from possible infections from viruses or bacteria or whatever. So also in the way it functions, HIV, at least as of now, cannot be cured because once it infects a CD4 T cell, it doesn't immediately kill it. What it does is it infects it, and then it has what's known as a latency period where it just sits dormant for a while. And because the immune system is not great at looking at itself, the other immune cells are not able to recognize an infected CD4 T cell as being something that they need to destroy. So you can't really get rid of the HIV virus completely once someone is infected with it. However, now with antiretroviral therapy, which is relatively new, you can decrease viral load in someone to the point that the virus is nearly undetectable in them, and you can have their CD4 T cell count come up to near normal levels. So with antiretroviral therapy, people can live very much longer lives, and people who develop HIV will probably, contract HIV will probably never actually develop AIDS, which is great because if someone develops AIDS, they are much more likely to have a much shorter lifespan. So these antiretroviral treatments are absolutely necessary, but they also will cause some problems, as I'll go over in the next slide. So, all right. Now for amputees, these are some other things that we need to take into account. People infected with HIV are actually 6 times more likely to develop peripheral artery disease than the general population. So they have some more vascular problems. Additionally, HIV is associated with decreases in HDL, which is good cholesterol, and increases in LDL, which is bad cholesterol. So the HIV itself causes more vascular damage. Additionally, the antiretroviral treatment is also associated with endothelial damage, and that endothelial damage is damage to blood vessels that results in their narrowing. So not only the disease itself, but the treatment for it, both of those cause vascular damage to these patients. Also, neuropathy in the extremities is very common for people with HIV, and this can be, again, can be caused by HIV itself and can be worsened by antiretroviral treatment. So in essence, these patients should be treated in a similar manner to those with diabetes, since they have similar difficulties of having these vascular problems, as well as typically having neuropathy in the extremities. But these patients need extra precaution to prevent wounds because infection could end up being life-threatening. So these patients, you really need to see them more frequently and be very thorough when inspecting their residual limbs to make sure that you don't see any signs of irritation. So those are just some additional factors that we have to take into account when treating amputees who are infected with HIV. All right, so now for our case features. This is our actual patient, LeBron James, classic. So he's relatively young, about 48, and he's a pretty big guy. Well, not huge, but he's a bigger guy. He's 6'2" and 180. He works as an accountant, so he's not very active. I mean, he's fairly active, but his job itself is not particularly strenuous. And he is a right transtibial amputee, which is secondary to osteomyelitis, which is secondary to his HIV infection. So he also lives alone, and his goals are to maintain his current level of activity, which is that he currently takes frequent walks around his community, and he doesn't traverse uneven terrain as well. But that's what he wants to be able to do, is continue to take these frequent walks around his community. All right, so his medical history. He contracted HIV in 2010, and he began antiretroviral treatment shortly after that. So he's been on the antiretrovirals for almost 11 years now. So he's been on them quite a while. He contracted osteomyelitis in his right foot in 2015, which was secondary to a toe injury. So this ended up leading to a transtibial amputation on his right leg in December of 2015. And then he got a definitive socket for that. And he had it for a little over a year before he had to get a new one because he had shrunk too much. And then he got another prosthesis in October of 2017, and he has had that prosthesis and that socket since then. So when he came in, we saw him, he was still wearing that prosthesis. Important to mention is the fact that when he contracted that osteomyelitis, he also ended up having a significant amount of damage done to his left leg. And it was actually so bad that he ended up requiring a crow boot. So now the way he gets around is he has his prosthesis on his right side, and on his left side he wears a crow boot. So that is definitely important to mention. And that crow boot was delivered in February of 2016, and he has been wearing that original crow boot this whole time. Now for our evaluation of him. When we saw him, he had a small ulcer on his distal tibia, and that's what he came in for. So right off the bat, we were very concerned about that. We wanted to try to prevent anything that would have caused that, and try to fix that as soon as possible because of his condition. So we went ahead and we also tested his range of motion and manual muscle testing, and those were both normal. He's quite flexible and he's pretty strong. And he has good sensation in his residual limb, but he has limited sensation in his left foot due to that peripheral neuropathy. His residual limb is also conical in shape, and that seems to indicate that he is shrinking even further. And when he came in, he was walking with an uneven gait. And what I mean by uneven gait is that he tends to favor his orthotic side, or his side with the crow boot on it. However, this could be due to the fact that he was feeling some pain from the ulcer on his residual limb. So maybe had he not had that ulcer, he would have walked a bit more evenly. Then for the condition of his current devices, his crow boot seems to be in good condition, and his current prosthesis is in good condition. However, he was wearing 8-ply when he came in, and that 8-ply was on top of a 6mm liner. So there's quite a lot of space in between his limb and the socket right now. He's shrunk quite a bit, and he has a single-axis foot on his current prosthesis, which is 5 years old, so that's getting a little old as well. And these are all of his measurements, and these measurements were taken over his 6mm liner. Now for assessment. So he is a K3 due to his ability to vary cadence, which is very nice. He has good strength and range of motion, as I mentioned earlier, but his current socket is too big. We really need to make sure that he gets a new one because of the fact that he is an 8-ply and he's still bottoming out, and he has developed that ulcer. So it's a big deal. We really need to get him a new socket as soon as possible to prevent him getting any sort of possible infections. TSB socket is recommended to create the best possible fit to avoid additional ulcers. That's just, TSB gets a better fit, and he did have a slightly conically shaped limb, but he wasn't so bony to the point that he would have required more of a PTB kind of style. And we want to be as gentle as possible on his skin, so we really don't want something that's going to cause more rubbing and things like that, like a PTB would, because it's not quite as good of a fit. So we're going to stick with the TSB, and it has been working well for him. It's just the problem is that his socket is too big now. So we also are going to stick with the pin lock suspension because it's been working well for him and he likes it. Additionally, because he lives at home, it's a little bit easier and less of a hassle for him than some of these other types would be, especially because he can't really ask for help because he lives alone. So pin lock seems to be a good choice there as well. Now, a new single-axis dynamic response foot is recommended, and this is due to the fact that his current one is 5 years old, so a new one would provide the necessary stability to prevent falls, which could be life-threatening due to his condition. Additionally, the dynamic response addition is good for him since he can vary cadence, so it will allow him to walk more efficiently throughout his community, which is a goal of his. And even though he's a K3 due to his ability to vary cadence, the fact that he tends to favor his orthotic side and the fact that on that orthotic side he's wearing the crow boot leads me to believe that he would struggle with traversing uneven terrain. So because of that, he could probably stand to benefit from the greater stability provided by a single axis foot, and it is not one of his goals to ever traverse uneven terrain, and he doesn't ever in his day-to-day life. So a multi-axial foot is likely a bit too much for him anyway, and it's also unnecessary. So now for our plan of care. So initially we gave him a distal end pad, and that was just so that he could have something in there to take some pressure off of that ulcer until his next appointment, because he had been currently going to wound care, which is nice, but we just wanted to allow him to heal, and taking any pressure off of that ulcer that we could would be beneficial. So we really wanted to make sure that we weren't going to make him take longer to heal. So it was very important to do anything we could, and the distal end pad was something that could help. Additionally, in the future, it could be a form of insurance against ulcers if he shrinks a lot again, but he doesn't have time to get into the office or something. Then he could use that if he felt himself bottoming out and he was in a bunch of socks. So it's just something else that could be helpful in the future. The pin lock components, that's obvious because we wanted to stick with the pin lock suspension. And then for locking liners. So we chose the Alps Easy Flex liner, and that's because it's indicated to use for sensitive skin, which we wanted because we wanted to reduce stress on his skin as much as possible to prevent opportunities for infection. And it allows for easy flexion, which is nice for increased durability, so it's not going to be quite as worn from his walking. Additionally, we chose a 6mm liner, which will further protect his skin from wounds. So we just really wanted to give him as much kind of padding as possible. Now, TSB carbon fiber socket. Carbon fiber is just, it's a standard socket design and should work very well for him due to its lightweight and its high strength. And he's not so heavy that he needs something stronger. So that should be totally fine. Now for the single axis dynamic response foot, we chose the Trias, which is, you can see here, and that's from Ottobock. And the Trias we chose because it's specifically designed for moderately active individuals who require a bit more stability, which is exactly who he is. He's moderately active, he could benefit from that dynamic response, but he requires a bit more stability due to his quote-unquote sound side being in a crow boot. The Trias is also a lightweight foot, which should help decrease his energy expenditure, which would be good for him because His energy expenditure, while he can vary cadence and he seems to be in pretty good shape, we do want to try to decrease his energy expenditure as much as we can, since on his opposite side he has a crow boot which is quite heavy, so he's going to be working harder because of that already. So if we can make his energy expenditure a bit less by having a lightweight foot, that's always something that we should do. It's a nice benefit there. And these are my L codes for all of the things that we had in the plan of care. And finally, patient education. So patient was instructed to keep distal end pad at the bottom of his first prosthesis until his next appointment. Patient was instructed how to wear a liner and his prosthesis. Patient was educated on how to wash and how frequently to wash his liners and his prosthesis. Patient was educated on how to don and doff this prosthesis and was able to do so alone without problems. Patient was instructed to perform hourly skin checks during the first week to prevent skin breakdown, and if any skin breakdown or redness lasting longer than 15 minutes was present, to stop wearing prosthesis and call the office. And finally, the patient has been an amputee for nearly 6 years at this point, and he has high mental acuity, so I am quite confident that he's well educated in his own care at this point. And these are all of my references. So that was my case study. Hope you liked it.